Thank you for attending this presentation. My name is Rebecca Rowe, and I'm presenting my DNP project on News 2 use in postoperative prostate resection patients in an extended recovery unit. Let me introduce my DNP project team. Dr. Lisa Ousley, my chair, Dr. Cynthia Newell, my site mentor, and Emily Kennedy, my content expert. Unit and leadership support for ERU was provided by Lynn Winnie, the manager of the extended recovery unit in this community hospital. So the extended recovery unit in this community hospital was selected as a pilot program site to provide care for patients receiving a new innovative robotic procedure for prostate resections for the diagnosis of benign prostate hyperplasia with lower urinary tract symptoms. The pilot was successful, and since then many medical providers have used this site to perform hundreds of prostate resections, making this a leading hospital for males seeking this type of procedure. And as the number of and experience of caring for these patients grew, the extended recovery nursing staff became aware of random episodes of clinical decline in this patient population. Many times it required escalation, further resuscitative treatment, and evaluation for a higher level of care. The nurses on ERU asked me if there was a way to detect these episodes early enough so that they could intervene in time, possibly not having to engage the rapid response team. And during that discussion with nurses, the use of News 2 as a tool option was introduced, and it was clear that a knowledge gap existed between what News 2 was and how to use it as an early detection option. It was also clear during subsequent discussions that the meaning of a complete set of vital signs was also inconsistent among them. This meant that there was also a knowledge gap in what the hospital policy required when collecting vital signs. I mention this because to use News 2 early warning score system properly, you have to have a complete set of vital signs at each News score calculation. Otherwise, it's inaccurate and does not work as intended. So this project aimed to answer this clinical question. Does the use of News 2 scoring system assist extended recovery room nurses improve early recognition of clinical decline and postoperative outcomes in prostate resection patients for benign prostatic hyperplasia? So let's talk about News 2 a little bit. In 2007, the National Early Warning Score, or NEWS, was created as a patient safety initiative by the Royal College of Physicians within the national health system in the United Kingdom. And it was because of increasing patient safety issues and poor patient outcomes in acute care settings in the United Kingdom. And these were all preventable issues. This creation allowed the United Kingdom's national health system to enable providers to determine, using this tool, severity of illness by combining sequential vital sign collection with patient assessment to track and trend changes in patient conditions, thereby preventing poor patient outcomes due to delayed or inadequate care. So the Royal College of Physicians wanted to review NEWS at the 10-year mark to validate its worth in acute care settings. And over time, technology and research and experience, a few additions to the NEWS parameters were added to help with understanding and decision-making for nurses on these acute care patient care settings. And therefore, in 2017, News 2 was created. It now replaced the original version and has been touted as a simple and trustworthy support to nursing assessment, managing plans of care, and promoting critical thinking and clinical judgment with use of a visual tool of triggers and thresholds to help make making those critical decisions easier. Where News 2 is utilized, education on the use and benefits of News 2 is a priority to improve patient outcomes in acute care settings. So besides News 2, when we talk about the postoperative prostate patient, the resection patient, that care of that patient is physically and clinically challenging. Goals of care in the immediate post-op period are supposed to be managing bleeding by placing traction on the bladder neck with urinary catheter and keeping the catheter patent by using continuous bladder irrigation. These two activities are time-specific and require meticulous observations by the extended recovery room nursing staff to ensure no obstructions appear and urine and irrigation flow freely to prevent bladder distension and the potential need for further medical intervention. The most encouraging movement in urology has to do with these innovative techniques, which we've been practicing for the last 5 to 10 years. And those techniques are utilized to preserve urinary and sexual function in males while removing the enlarged prostate, providing a quality of life that heretofore was not previously experienced. With research revealing a 10% postoperative morbidity rate following prostate resections for BPH, the need for improving decision-making and building upon clinical judgment of the nursing staff to accurately communicate clinical findings and to those providers and to rapid response personnel improves the chances for interventions that would reduce the need for higher levels of care, reduce the length of stay, reduce cost, and reduce the postoperative mortality rates. Puzzling though, the cause of the clinical decline in this extended recovery unit patient population varies, and emphasizing the importance of determining best practices. In this context, News 2 is a simple early warning tool that allows the primary nurse to follow the path of vital sign frequency from admission to look for trends in increasing calculated scores. It has been validated as an adjunct tool to predict early signs of clinical decline as much as 7 hours before the event. The extended recovery unit acute care postoperative environment best suits the use of News 2 due to its short stay culture. But within the literature, the use of News 2 in postoperative phase of care is not widely researched, and challenges continue regarding ways to improve facilitation on the proper use of News 2 and outcomes related to it. Early intervention using News 2 recommendations may provide this threshold of when to notify providers and receive treatment orders, and it could be a keystone finding for us, leading to protocols for the appropriate use of rapid response teams and emergency response teams. But just like anything else, how you use your tool is how well it is useful for you. So this is a tool, and regardless of what early warning system is used, if a nurse in collaboration with another nurse or patient's care partner feel that something's just not right with the patient, activation of rapid response team and the provider takes precedence over everything else. So just to understand the significance, there's a clinical decline can be detected about 7 hours before the occurrence, 10% morbidity rate alone in prostate resection procedures, 25% or a quarter of all surgical patients experience a postoperative complication, and the integration and interpretation of information gathered during routine monitoring remains highly dependent on clinical judgment, which for new nurses takes time and experience to gain. The framework selected for my project was the framework for safe, reliable, and effective care. This framework evolved out of a period in healthcare history when medical errors and preventable deaths in hospitals were occurring at an alarming rate. Patient safety and preventable deaths in acute care settings became the focus, or which drove the creation of early warning systems and rapid response teams within healthcare settings. The importance of education, leadership, and culture on how nurses can safely communicate findings with providers and resuscitation teams to get the best outcomes for the patient is critical, and it's very much needed. The type of culture that this framework provides in this illustration resonated with me because I felt like education is just as important, or the learning system is just as important as the culture in this situation. I felt very honored and fortunate that the ERU nurses felt comfortable enough to not ignore what they were seeing, but to show their caring and practice ownership in seeking ways to anticipate the needs of their patients, specifically this patient population, and provide optimal care to achieve positive patient outcomes. This project defined the process that we were attempting to improve, and therefore the method chosen provided familiar metrics to the ERU nurses, which is what this framework recommends. The ability to quickly assess interventions and retest and reevaluate for change is the hallmark of a quality improvement project. And it helps stakeholders keep track of the incremental progression of the project and percentages of improvement along the project's timeline. So to sum up what the problem statement was, is the extended recovery nurses reported episodes of clinical decline in postoperative prostate resection patients with benign prostatic hyperplasia, and asked if there were ways to anticipate or predict these episodes. And while News 2 was established in the electronic medical record for the ERU documentation, nurses' reports and past medical record audits verified that the overall use of News 2 was limited and inconsistent. It also was discovered that what constituted a complete set of vital signs was a variable translation among the extended recovery nurses. So we provided a literature search for everyone. This was conducted using multiple databases, including CINAHL, OVID, EBSCO, and others. And the terms used were early warning, failure to escalate, failure to rescue, vital signs, news 2, clinical deterioration, and postoperative were searched and reviewed. The literature revealed that the use of early warning systems was recommended, and that there was actually a knowledge gap among nurses on the benefits and use of early warning systems. And current research surrounding nursing or healthcare providers' attitudes towards the use of an early warning system was that a bureaucracy was just adding another layer of work to their already burdensome workflow. The literature search provided many references to the global challenges related to patient safety and the perceived need for the implementation of an early warning system. Emerging themes help provide context for the planning improvement interventions. And you can see that Pettit et al. Is our resource that cited approximately 25% of surgical patients had postoperative complications, and that patients admitted to med-surg patient care units have a higher probability for failure to escalate or rescue due to nurse staffing ratios. And then a prospective cohort study addressed early in the COVID-19 situation in 2022 that they started using this News 2 score in 2020 and found that it was helpful in predicting severe disease and in-hospital mortality from COVID-19. The 4 emerging themes that came to light with this literature synthesis were vital signs, early warning system, News 2, failure to escalate, respond, and rescue, and improvement strategies. And related to vital signs start the patient assessment process, and they help create the plan of care. Vital signs are necessary for News 2 scoring, and nurse leaders look at workflows to determine productivity and staffing needs. One study that we looked at attempted to discover the time and amount of work involved and found it was nearly impossible to provide planning information based on the variability of methods and equipment that were used in these acute care settings. Another study suggested that overcoming time constraints on collecting vital signs should include using equipment that directly integrated into the electronic medical record, making it much easier to communicate those vital signs in a timely manner to the primary nurse to facilitate early interventions. We look at those trends. The early warning system, a News 2 theme, showed that it's a relatively new addition to patient safety initiatives since it was started in 2007 and reevaluated in 2017 for relevancy and quality, and provided evidence-based guidelines and a tool to score patient status. The systematic reviews comparing multiple early warning systems determined News 2 to be reliable in predicting escalation to ICU care or death within 48 hours of the event. Failure to rescue, escalate, and respond in the literature revealed alarming challenges within healthcare cultures. Cortuando et al. Recommended collaborative approaches to perioperative care to form quality improvement to include patient assessment, early warning system use, systems, and environmental bureaucracy as contributing factors in failure to respond to clinical deterioration. Other qualitative studies cited nurses' negative experience in communicating with providers or rapid response teams, causing reluctance to inform patient status in a timely manner. In short, they were afraid to call. The improvement strategies that were found in this theme for patient safety in perioperative settings include preoperative optimization and discovering undiagnosed issues before scheduling elective surgery as a trending recommendation to help eliminate poor patient outcomes. And that discussion goes on today. Episodes of clinical decline reviewed in root cause analyses produced a recommendation of recognize, relay, and respond as a new paradigm to promote all healthcare providers to support proper controls, enabling the use of tools to respond to patients in crisis. Concerns over the number of experienced nurses retiring. One of the improvement strategies was to pair novice nurses with experienced nurses to help build critical thinking using tools that guide appropriate responses and thereby growing clinical judgment. Apart from the merging themes, there were some seminal documents that were also used and included in this project, which related to the Royal College of Physicians' creation of a new scoring system, and also the VA's evidence-based synthesis of research on early warning systems use. The use of early warning systems is a new addition to patient safety initiatives, and as recommended in the study, plans to design a focused approach to evaluate this tool for improving nursing staff response, regulatory compliance, and patient outcomes was a very interesting research point. The Joint Commission provides regulatory guidance and accreditation for this community hospital where this DNP project was performed. And in this Joint Commission standard, in the Joint Commission standards, the patient care element of performance, PC 020119 EP2, describes using a developed written early warning system criteria, defining early warning signs of change or deterioration in a patient's condition, and when to seek further assistance. And that was from 2023. Tools provided by the NEWS2 scoring system are currently transcribed into the electronic medical record as resources. So the purpose of this project was to evaluate nurses' use of NEWS2 before and after education on the NEWS2 protocol for earlier detection of clinical deterioration and improved outcomes. The aim of this quality improvement project was to determine whether educating ERU nurses on the benefits and proper use of NEWS2 would increase the use of NEWS2 scoring for earlier intervention and timely discharge home from ERU. And why was this needed? Well, during the project, there was not a policy mandate to perform NEWS2 to the cadence or frequency of vital sign collections in the extended recovery unit. There also was not a consistency in complete vital signs collection, which directly ties to the accuracy of NEWS2 score calculations. The ethical considerations in IRB approval were completed by the University of North Georgia and Northside Hospital from October to November 2023. The risks and benefits were carefully considered. Informed consent was obtained by ERU nursing staff who were recruited and agreed to assist with this project. Patient confidentiality protected by removing patient identification criteria. Patient confidentiality protected by redacting from chart reviews, and patients were randomly listed on worksheets during the 4-week periods. All data was kept secure. The Plan, Do, Study, Act model or PDSA model was chosen for its efficiency and expediency for testing and evaluating interventions during the project. Plan was to test the change by collecting EMR data from all prostate resection patients 4 weeks prior and 4 weeks post NEWS2 education for ERU nurses. The Do was the actual education, beginning with the overview of NEWS2 scoring system, the reason for its creation, benefits of use, barriers to use, tool validity and reliability, and how it fits into the electronic medical record. This education was provided at staff meetings both in person and recorded using the Zoom platform to ensure consented nurses receive this education. The definition of what constitutes complete sets of vital signs was addressed, and hospital policy was reviewed to show the definition of what that meant, and that was one of the reasons to focus on how these complete sets of vital signs have an effect on the appropriate news scoring. The rationale for why complete vital signs are necessary is essential to the accuracy of News 2 scoring calculations, and we had measurements of pre- and post-project implementation regarding the use of news that was reviewed 4 weeks before the project start date and concurrently 4 weeks after the start date to use the pre-project start as baseline percentage of compliance for documentation of vital signs, News 2 scores, and calculations. The study was the electronic medical record review for 4 observations outlined in the project and approved by the IRB and data use agreement. The act was to share results and analysis with the ERU nurses and organizational stakeholders, and to use this project as a springboard to edit unit-based policy regarding the vital signs collection process and facilitate electronic medical record layouts to ensure nurses see News 2 in close proximity to the recorded vital signs and associated parameters, while also improving compliance with the goal of recognizing thorough News 2 calculations, better decision making. Dissemination of the project with others and ongoing monitoring of outcomes in the organizational extended recovery units may lead to improved outcomes in clinical judgment, and many future research studies could spin off from this project's impetus. So to ensure that I looked to ensure validity, I looked at 100% of the postoperative prostate resection patient records, which due to the assignments made by unit leaders included the consented ERU nurses. The number of charts reviewed were approximately the same pre and post intervention. So we looked 14 ERU nurses signed informed consent to participate in the project. That made up 67% of the ERU nurses that are on the nursing staff roster. The chart sample were 100% of postoperative patients with prostate resections for BPH, and that was 36 pre-education or intervention and 34 post-intervention. The setting was an 18-bed extended recovery unit within the North Georgia Community Hospital, and it is a short stay unit optimally providing 24 to 48-hour observation or less, sometimes more. Stakeholders were patients receiving postoperative care for BPH in the extended recovery unit, the ERU nurses, of course, unit-based leaders, hospital policy writers and reviewers, and perioperative organizational leaders. The intervention included News 2 education, and education was provided by presentation live and recorded and on Zoom to ensure that all consented RNs received this education. And this education formed a baseline of information related to why ERU used News 2, the benefits of its use, and how scores were calculated, with completed sets of vital signs within the policy. Policies were within the hospital system were also covered to ensure individual interpretation of vital sign collection was corrected and tied to the accuracy of News 2 scoring. One other benefit of this education was presenting the official scorecard and thresholds that formed the scoring documentation in the electronic medical record. The data used for sharing followed the data use agreement guidelines and IRB ethical safeguards protecting health information and confidentiality. The data included the baseline percentage of compliance after each intervention, PDS cycle evaluation, and final summary of findings. The data results were reported at staff meetings, huddles, and posted on ERU Quality Improvement Board. When creating the News 2 scoring tool, review groups across the national health system in the United Kingdom provided a large working database for healthcare workers to use and evaluate the tool. And the Royal College of Physicians, or RCP, used 2 approaches for this validation. It was a desktop evaluation of the News tool and a comparative study showing News 2's ability to predict cardiac arrest, depth of or ICU admission better than other of the in-use early warning systems within the system. The reliability was proven by a longitudinal study comparing News 2 with other early warning systems in mass casualty triage centers. And then standardization across the National Health System indicated News 2 reliable. In a 2019 study where at a mass casualty triage center, researchers studied several scoring systems to predict mortality within 48 hours and found that News 2 was easy to use and facilitate and proved a valuable tool in determining effective and timely triage. Additionally, the speed at standardizing News 2 is indicative that this News 2 the early warning tool was valuable in predicting clinical decline in a variety of settings and has grown to include ambulance and primary care settings within the UK. And it also has been adopted internationally. It is seen as a pragmatic, patient-centered tool that has grown in use around the globe. So News 2 Instrument and Response Guide, this gives you an overview of the tool that's approved for us to use, and it shows different physiological parameters scored from 0 being your normal to either high or low on either side. Each increment of high or low is given the same numerical score of 1, 2, or 3. At each vital sign collection and patient observation, these physiological parameters are scored by the highs, the norms, and the lows. The scores are tallied in the electronic medical record and for the scores. And the numerical scores of patient assessment determine the need for prompt action via communication with primary nurse provider and rapid response team. And you can see that not only vital signs are included here, pulse oximetry is listed there. Are they on room air or are they on supplemental oxygen? Do they have any change in their level of consciousness or a new onset of confusion? And so that's what is new and added to the overall parameters. This one, to me, is the most important thing regarding clinical judgment and building that clinical judgment skill. And it's looking at the thresholds and triggers when you have a scoring system in place for early warning clinical decline. Aggregate score of 0 to 4 is low in its ward-based response, which means that you would confer with folks in your unit to help you with an assessment if you had any question before you escalated care. If it was a score of 3 in any individual parameter, that would be a low or medium clinical risk, and that would make your scoring a little bit more urgent, and that you would probably call the provider at that time. An aggregate score of 5 or 6 would be medium, which would be a key threshold for urgent response, and that means that you would probably include your rapid response team before it got full-blown into a sepsis or a code blue situation or a cardiorespiratory event. Any aggregate score of 7 or more is high, and that would require pretty much a code type of response situation. The big thing for post-op care is the sepsis. If you can catch that before patients go home, which the majority of our patients go home within a very short period of time post-operatively, it is very important to try and use some kind of tool to detect any signs or symptoms of clinical decline before they're discharged home. To explain these expected percentages, I looked at what was the policy, what was actual practice demonstrated for vital signs, and what was not mandated, and what were uncontrollable outcomes, and to determine what we could find in those 4 observations. From baseline data to project results, the improvements consisted of these 4 variables: the number of post-op patients with documented News 2 score, the number of complete vital signs documented. Those were 100% because they are, if you have documented vital signs, it's very simple to have News 2 scores evaluated. The number of News 2 scores are calculated responding with vital signs. Put that as 85%, mainly because some of the vital signs are already incorporated through equipment. Some have to be placed manually into the electronic database, and so if that's the case, some of those may not be placed in a timely manner. So I gave that 85%. And the number of patients discharged home from ERU in this patient population, I set an expectation of 75%, mainly due because the particular patient has these episodic clinical events that are variable in symptoms, and we're not quite sure what caused those, and it's not quite sure how they're going to respond to treatment and be able to be discharged home from extended recovery. So I gave that a 75%. Data collection started in mid-October and education was performed in mid-November. The subsequent 4 weeks were extended into January to correct for the holiday weeks where no elective prostate resection patients for BPH were noted. As stated earlier, 100% of prostate resections were audited for these observations. This analysis showed that during the 4-week period prior to education, there was one patient that had missing a complete set of vitals. Therefore, the calculated news score was not documented, so 100% was expected, and the threshold, therefore, pre-op observation was not met. Post-op threshold was 100%, therefore threshold was met, showing an improvement after education and weekly results reviewed interventions. On the third observation, the number of news scores accurately calculated, the expected threshold was 85%, and in both the pre and post-educational audits, that threshold was met. And on the fourth observation of patients discharged home directly from ERU, one patient in the post-education audit required admission to an inpatient care unit from ERU. The expected threshold was 75%, and this threshold was met. What this demonstrated was that the explanation and clarification of what the policy deems as a complete set of vital signs assists in the accurate NEWS2 scoring, enabled the nurses to further access patients for increased monitoring, anticipation of trends based on vital signs, and other NEWS2 parameters, and how to educate patient and family for reporting observable trends not normal for the patient, which are some of the non-vital signs metrics used in this early warning scoring system. It also revealed that patients with higher NEWS2 scores may need further observation in an inpatient unit before discharging them home, which provide improved outcomes. The project limitations and potential barriers of this particular project, it was conducted at one extended recovery unit within the hospital organization. The nursing staff attrition and temporary nursing staff required repeat initial training. The nurse bias against the use of NEWS2 was a possible limitation. The manual entry of some variables into the EMR could be a potential barrier or limitation. And the lack of policy to ensure consistent NEWS2 use with appropriate calculation with each set of vital signs was also a limitation. Some potential barriers had to do with the lack of clinical experience by ERU nurses. In some of our med-surg units and our extended recovery units, some of our newer nurses and nurse residents take their initial job in this particular unit. The lack of empowerment to escalate and report changes in patients' assessment due to negative responses from providers or rapid response team members could be potential barriers, because the fear of calling someone to be yelled at or felt less worthy is not something that people want to really jump into. They have to overcome that fear to be able to make that phone call. The lack of clinical support to maintain optimal staffing ratios is really important, because these particular patients require a lot of physical and clinical expertise and work to be able to maintain that urinary catheter flow and management of bleeding. The project conclusions and benefits: the use of NEWS2 will be in the revised ERU policy to ensure improvement in documenting the necessary components for calculating the NEWS2 score after education was provided. The innovative platform was utilized for disseminating information to the extended recovery unit nurses, and recording education provided opportunities for nurses to review and revisit the content regarding NEWS2 use and benefits. The benefits of this project: assessment tools provide opportunities for extended recovery nurses to grow in clinical judgment. The use of NEWS2 provides data to empower nurses when communicating clinical assessment findings to nursing leaders, providers, and rapid response teams, not in the particular numerical score, then in their ability to articulate assessment findings that are factual and actually have some validation in the actual graphics and their physical assessment findings. And the benefits of this also is that patient outcomes are improved. The results and findings were shared with the extended recovery room nurses and stakeholders, and plans to publish this project are ongoing with peer-reviewed journals relating to perioperative services that include extended recovery unit relevance. Disseminating the findings do provide quality improvement applications related to postoperative outcomes using News 2. And as I said, research on this particular patient population and the postoperative phases of care are limited in research. So it provides some opportunities for that as well to expand on research nurses. The process for extended recovery and nurse utilization of News 2 may also benefit the growth and development of clinical judgment abilities, especially when using the threshold guidelines. So the discussion continues. Opportunities existed to evaluate the nurse's knowledge and use of an evidence-based early warning scoring system to improve the ability to detect a clinical decline in ERU. Using a quality improvement project design supported by an IHI framework and educational intervention provided extended recovery room nurses with increased knowledge and of News 2 as a patient safety initiative, not just added burden. This project closed gaps in News 2 use, clarified what constituted a complete set of vital signs, and how incomplete sets of vital signs render News 2 scoring or for trending clinical decline ineffective. And using a specific patient population as an example for consistent use of News 2 can be generalized for use in all ERU patients to evaluate for clinical decline before discharge. Thank you again for the opportunity to present this project to you. I also want to thank my project advisor, mentor, content expert, and my unit leader support, who all assisted me in bringing this project to completion. Following slides are my resources. Feel free to click on the QR code and see a full list of my resources there. Thank you again.